Okay, so okay, so there's just a little bit left that I wanted to go over about speech production and a few clinical concerns as well. So we'll do those very briefly. So during conversational speech, the rate of breathing is about the same as typical quiet breathing. It's approximately 12 breaths a minute. And of course, that's going to change with different things, right? So with exercise, we're going to talk a little bit about exercise here, but more speech intensity. So, talking faster, talking more animatedly. If you're under cognitive load, if you're exercising, that can all change your ventilation rate. It's not always going to be 12 breaths a minute, but regular conversational speech and typical quiet breathing is about 12 breaths per minute. If you're a person from a low elevation, so like down here where I am, in Phoenix, near Phoenix, if I go up towards Flagstaff, or if I go to Colorado, probably I'll end up speaking under much higher drive, which is going to mean that I have to take in more air more often. So I have a greater ventilation rate. Of course, anytime any of us are exercising, that's going to be a similar thing. So greater ventilation rate, you're going to have fewer syllables that you can produce per breath because you will get them out, and then you need to take in another breath. That's a consequence of the greater ventilation rate. You'll have higher than typical airflow in voicing, so each word will expire more air. There's also going to be non-phonated expirations, so if you've ever been on a treadmill and trying to talk to somebody, you'll talk to them, and then you'll have to blow the rest of your air out and take some more in. And the reason for that is you're under load, right? And so you need to be able to take in more air to get oxygen to the rest of to the muscles that are working, right? So you'll expel air and breathe it in. That doesn't usually happen with typical conversational speech. We don't just, sigh when we're not intending to sigh, essentially, is what that's saying. But all that said, our breathing ends up being coordinated with our speech. All right, so now this is really interesting, some cognitive components of speech breathing. So you've probably noticed this in your own breathing or listening to my lectures. If you listen to podcasts or audiobooks, you'll hear this as well. Usually we'll place our inspirations where there's something that's already breaking up conversation. And these are grammatical rules, right? So anywhere you have a comma, a semicolon, or a period is a place for you to be able to take in air. And now that I've put that period there, I will breathe. That was too much. So inspirations are usually longer when followed by longer breath groups. So all that means is it's kind of like you anticipate what you're going to say, right? So if you know that there's not going to be a comma coming up or a no semicolon, so if you're explaining something that's going to be maybe a run-on sentence or something like that, you will take in a much larger inspiration in preparation for that. So there's a lot of coordination between what's going on cognitively and thinking about how you're going to be able to convey information and actually taking that information in. And then this is crazy too. So there's different things that we do with our breathing depending on cognitive load. So depending on how difficult a question is to answer. 200 to 250 milliseconds, this could be enough to just think about a response, right? So somebody asks a question and you think and then you answer. It's a very short pause. Anything longer than that means that there's some cognition involved in there as well. So that's not to say, I guess that was probably poorly stated. there's definitely cognition going on in formulating a spoken response all the time. But what I mean is thinking about a problem, doing some problem solving. So instead of just like, hey, how are you? Where'd you go yesterday? And you just have to like generate a spoken response, and that definitely requires cognition. Let's say that you don't remember, because that happens sometimes. So then there would be a much longer pause, because in addition to just formulating the response of, I don't remember what I did yesterday, you also are trying to cue your memory and try to figure out what you did. So there's extra layers of cognition on top of there. With a low cognitive demand question, you would expect that the pause in speech would also be coupled with an expiration. So the person might breathe out and then answer. But under high cognitive demand, people tend to hold their breath. So they'll pause and keep the breath that they have had. And so that's one interesting way. These aren't, 100% all the time, but it's correlated. It's a significant correlation that low demand questions are correlated with expiration. High demand questions are correlated with held breath. So I think that's an interesting thing. One other thing that I think is interesting is this conversational dynamics, but I should say that overall, dynamics is something that another aspect of my research, and we kind of approach problems differently. So a lot of times when scientists, including myself, look at certain things, we want to know the average, right? So like, what's the average height? But dynamics is something that's going to look at change over time. So if we think about average height, doesn't really work in this case. I mean, we know that people get taller as they get older, and then I guess shorter as they get really older. Actually, I guess that does work then. So we can look at someone's average height, and just one person, their average height over their whole lifetime. And we can say that they're about 6'1" is about the average, or maybe 6, because there are some times when there's lower values that are going in. But there's a lot of time when I'm at 6'1", so it might average out to about 6. But dynamics is going to look over time. And they'll be able to show that, oh, well, you're really small when you're a baby, and then as you get older, you get smaller again. But there's also an interesting thing that happens while you are just awake during the day, which is that you get shorter over the course of the day. And then when you go to sleep, when you lay down in your bed, your body is able to like kind of stretch back out. And so then when you wake up, you've become taller again. So dynamics is the analytical approach that would let you notice that you get shorter at the end of the day. And this isn't like, microns or something like this. This could be for some people like an inch. So I don't actually know when I've usually measured my height. I don't know if it's morning or night usually, but so I could be 6'2" sometimes and 6'1" others, or maybe I'm 6'1" and 6. I don't really know. But it's definitely a noticeable, not like noticeable to the eye, but noticeable with a tape measure kind of change. Anyway, in terms of speech, dynamics is going to be looking at coordination between two things. So we can look at just one, individual or one aspect of something and look at change over time, but we can also look at two and how they change over time. But naturally what you want to do when you look at two things that change over time is figure out, are they linked? Does one push the other? So does A push B? Does B push A? Do they both influence each other somehow, but neither one is a leader? And what we do see is that there's a huge amount of synchronicity between ventilation and speaking cycles. So this picture I've got here, like we've got Obama speaking right now, Harry's listening, and so you would expect that his breathing patterns would be mirroring his speaking patterns. Pretty crazy. Which is just what what these are saying, right? Both of those points. We can also notice, and this is from the other dynamics literature, look at their hands. I guess this is the right hand, yeah, because I'd have to turn around. So the right hand of the speaker is up making a point, but the right hand of the listener is kind of mimicking what's happening. Both of their left hands have almost exactly the same posture. It kind of looks like maybe they're composing like a rap, is kind of what it looks like. But who knows what they're doing. But there's a lot of synchronization going on. And this happens, notice, like, think about it the next time you're having a conversation. It'll happen more with somebody you're close to. It'll happen less with someone you've just met. However, over the course of talking with someone that you've just met, if it's a good interaction, you'll notice that you start to synchronize. This is really true if you're going on a date. So if you're going on a date with someone you know, like if you're married and it's a date night, the synchronization will probably be apparent immediately. But if you're going on a date with someone that you've pretty much just met, and it's going well, so if you're doing this is what I want you to do. Look at how their actions mimic yours in the very beginning, and then as the date progresses and goes well, then take a look and see if anything is syncing up. And you should put that on the Slack channel. I'm totally interested to know. I'm sure everybody else is also interested to know. Out of 50 people, there's got to be at least one of us that's going on a date, and hopefully it goes well for you, I guess. Anyway, and also for this science. All right. So then let's talk about some clinical concerns for a minute. There's different ways to measure. Dr. Weinhold went over some of these, so I'm not going to spend a whole lot of time on it. But the spirometer measures lung volumes. That's this guy right here. Can just plug right into a laptop, and you end up with lung volumes. A pneumotachograph, I don't think I have a picture of. No. That's not true, actually, because this has two different pressures here. This is a pneumotachograph. So this measures flow during speech. You could have different ones of these. You can have some that look like kind of like a CPAP machine, where it might just go over the mouth, and that'll measure flow during speech. You can have these divided nasal passages, so it'd be one that goes over the entire face like this, but then it would be divided here, so then you can measure airflow during speech from the nasal passages and from the mouth. A pneumograph is actually just, it's not something you breathe into at all. Notice that it's measuring changes in volume, so it's actually just a wire that is sensing pull on it. So it'd go around the chest, and then as someone speaks or breathes in, it's measuring how much pull is exerted on this wire, and so that's going to tell you the volume of the chest cavity. And then you've got a manometer, which can measure pressure in a whole bunch of different places. So you can measure the mouth, just right in the mouth. You can measure down in the trachea, or this is kind of crazy, you can put it into the esophagus, so where food would go, down and go through the diaphragm and measure pressure below the diaphragm that way. So that's kind of interesting. So these are a bunch of different techniques to measure breathing and pressures. These are definitely on the exam. Parkinson's is an interesting, I'm really interested in Parkinson's. It's an interesting disease. One thing that happens is that, we know that it's the shaky disease, right? But what can also happen in some areas is that you end up with increased muscle rigidity. The reason for this, and this is actually going to kind of relate to phonation as well, with the vocal cords, but what ends up happening is sometimes people with Parkinson's will exert a lot of energy to make sure that the muscles are really forced together, right? So if we're talking about vocal folds, they're going to make sure that they're pressed very tightly together. If we're talking about breathing, they're going to use the muscles that they can exert more cognitive control over. And that means that they're going to be using a lot more ab movement than rib cage movement when they're breathing, because of this increased muscle rigidity and unconscious movement that can happen as well. So the intercostals aren't as useful to them because it's difficult to cognitively control these. The abs, there's a little bit more cognitive control that they can exert over those, and they're also larger muscles, so they can exert more force that way too. So a lot of times what happens with Parkinson's patients is they'll kind of overestimate the force that's needed. So they'll breathe out too much, they'll breathe in too much, because if they don't, they might not take in enough air. So it's better to overdo it than to underdo it, I suppose. You end up with kind of a soft monotone speech coming from people with Parkinson's. This is, due to not having adequate muscular control. What'll sometimes happen is it'll be soft and monotone with this pressure from the abs, and then sometimes if they're trying to force air out to make a point, do a little bit of this happens at least once a video. One word just totally, they're trying to emphasize a point. They're trying to emphasize a point, and they'll say it a little bit louder. It might come out really loud, much louder than intended, because of this kind of spasming muscle problem. So soft monotone speech is characteristic of people with Parkinson's, with occasional bursts of strange activity. And then, like I said, we'll talk about this more when we get to phonation, but you end up with the actual vocal tone being breathy or creaky or tense. And this is because of the vocal folds. So breathy is saying that the vocal folds aren't held together as much as they should be. So a lot of respiration is flowing out unused, essentially. So they're going to have to breathe a little bit more. Maybe it's harsh or creaky, and that means that the vocal folds are pushed together too much. And so then it's really hard. You have to use more pressure to force the vocal folds apart. So there's more pressure on the respiratory system to speak that way as well. Cerebellar damage, you should know this. Ataxia is something that can happen with cerebellar damage. Does that ring a bell? And ataxia, you've got uncoordinated movements or weak movements, strange timing, because the cerebellum is very involved in making sure things are adequately timed together. Because of these uncoordinated movements and the strange timing, you might get that their pressures in their lungs, their breathing pressures are normal, but the control of that pressure is poor or untimed, mistimed. So they might breathe in when they don't really mean to. There might be speech happening when they decide that it's a good time to breathe in. You can have strange, beginning and ending lung volumes, which is kind of similar to what we were saying. So they might begin speaking before they've taken in enough air and end way below where most of us end. So it gets really, just kind of creaky and really struggling to speak. Then another thing you get is a very robotic sounding speech. This video I'll have on Canvas for you to watch as well, but this is somebody with cerebellar damage, and you can tell that there's just a lack of coordination between the respiration, between phonation, between the actual effectors that are making the sounds. None of it's really working together. And there's weakness as well, which you would expect from cerebellar damage. So that's all kind of part of the same, issue. It's all from that cerebellar damage. Spinal damage, you would assume that, there's a lot of areas of the body that are paralyzed with spinal damage. And that's true depending on the site of wherever this lesion is. A lesion is what we call, where damage has happened in the spinal cord or in the brain or anywhere is a lesion. But wherever this lesion is, where the spinal cord has been severed, you might end up with paralysis in the stomach, which means that you have a hard time breathing out with your muscles of forced expiration. You may have paralysis in the chest, which means you have a hard time using all of those muscles of both inspiration and expiration. Because of that, you have this. You have increased abdominal size. There's nothing to counteract the movement of the abdomen, right? If the abdomen is paralyzed. So what happens is volume can't be controlled as well. So I mean, certainly people with paralysis can breathe. Usually, unless it's, well, that would have to be cerebellar damage. Yeah, people with spinal damage, any spinal cord damage should be able to breathe. That's controlled by a cranial nerve, not a spinal nerve. But their fine control over the respiration is lacking. So they use this thing called a truss, which is right here. And what they'll do is they'll push up against it, and it kind of acts like a hard surface to push against. So if they push their chair right up and lock the wheels in place, and they have this hard thing pushing against their abdomen, then they can breathe in. It forces the chest up, and they're able to breathe out more in tune with their speech, right? So they're not having to wait for their abdomen to use this little thing called a truss right here. So what they do is they move their chair forward, kind of lock the wheels in place, press the truss up against their, well, again, you can't see my stomach down here, but you push up against the stomach. And then as they're speaking, they can kind of lean into the truss and use that as effectively muscles, right? So this, this depends on, well, I guess it's not necessarily lean, but it's kind of like maneuver their body with the chair and the truss to have better control of the respiration that's coming out, right? So that gives them a lot more control to push air out. They can project their voice a little bit better when they need to, and have more natural sounding, loud speaking. It's really the volume and the very fine control over some ending words that they have a problem with. And the truss can help that if they're kind of using the chair and the truss to maneuver to act like ab muscles, essentially, to squeeze the abdominal contents so it forces the diaphragm up. Just another way to get there, right? And then the last one is mechanical ventilation. So what you've got here, this is non-invasive ventilation here. You might see this in hospitals for temporary use or for someone who's not unconscious. A lot of invasive ventilation is used when the person is out, medically induced coma or coma from anesthesia. Well, it's medically induced, I guess, but also, from injury. So these are going to be forcing air in, right? And so that makes it difficult to speak. So you have reduced control over what you can do. You don't have control over when you can breathe in and when you can breathe out. This is all being controlled by the machine. Also, really quickly, I want to make a brief aside. This right here is an iron lung. They're not really in use anymore. We have better and much smaller ways of taking care of this. But essentially what the iron lung does is it kind of acts like another layer of a lung in the whole process. What that means is, like, I know that doesn't really make any sense, right? But so we've got pressures, positive and negative pressures, right? And so what this does is inside the iron lung, there's going to be positive and negative pressure. And so we've got the lungs, we've got the rib cage. The rib cage moves and the lungs move as a result of that. Well, the iron lung either increases or decreases pressure, which then moves the rib cage, which then moves the lungs, and that allows air to flow into the system through this guy's nose and mouth. Right here. So it's all in here. Obviously the volume doesn't change of this area, but it's got mechanical control, so air is going to be pushed and pulled in and out of that. It's going to it's going to change the pressure by changing the constant, which is usually not something that can be done except by a machine. So the machine is changing the constant, which then changes the pressure. The volume is held constant in this case. Chest expands, lungs expand, air from out here flows in. This guy is actually one of the last people in the United States who are on an iron lung. Most people aren't anymore. There's a lot of better aids that we have, but he's one of the last. He's also one of few remaining people who were affected by polio as well. So he's put in this iron lung as a child. He's a lawyer in Texas, and anyways, lived pretty much his entire life in this iron lung. Okay, so where was I? So right, your breathing phases aren't coordinated with speech timing, which makes sense. They're there to provide inspiration and expiration. They're probably timed more to tidal breathing, depending on the setting, but usually they're timed to tidal breathing. And so obviously they're not timed with speech, they're not timed with sentences. Some of them have ventilators and valves, and you can change the rate of inspiration and expiration to accommodate speech. So these right here, depending on the system, depending on how long they're intended to be used, you might have that variability. This one looks like it's just a simple, someone is having a reaction to, I don't know, medication. Maybe they're having an asthma attack or something like that. So this one would just go right over, and it's a pretty simple machine, in and out. Others have more of a digital control board up in this area, and those can be used to change the rates of inspiration and expiration. And then if the inspiration isn't coming as fast, right? So if it goes to 10% versus 40%, then you can actually talk and then take in air when you need to. This is true for some the oxygen tanks that come around the nose as well. People can have timing valves on those as well, and those can accommodate speech or not. Sometimes people just take them out when they're talking, and I guess that works too. Another thing that you can do is you can retrain these patients in timing their own speech. So with an older kind of model like this iron lung, this guy's had to learn when to talk and about when the inspiration is going to happen again, so he can wait for that to happen and not try to speak through it. Somebody who's on long-term ventilator like this, or like we talked about, the oxygen coming through the nose, may retrain their speech timing, or like I said, they might, with the last one, they could take it out. So those are ways around it. And this is something that you could do as an SLP. You might help them retrain their speech timing. or you might help them learn how to use the valves and rates on the different helping items that they might have. So these are things that you might do if you're an SLP in a, not a school obviously, but in a hospital setting or possibly in a private practice setting. Those are two possible things that you might end up doing. I think that's my last slide. It is. Okay, so there's a quiz and a lab, and then the exam should be open today as well. It's not due for a week, but go ahead and look over your quizzes and labs and any of the other point heavy things that I've given. Not point heavy, I shouldn't say that. Anything that I'm giving you points for doing, there's going to be some clickable, kind of like a quiz, except it's not worth nearly as many points as a quiz. So it's kind of just like a homework or an activity. So look over those, look over your quizzes, and then you should be ready for the exam. And I'll post a review slideshow as well. I won't post a review video, but you'll have some PowerPoint slides to take a look at before you take your exam. As always, starting last week, I'm going to be on Slack between 10 and 11 on Thursday. So if you have any questions about anything that we've gone over, come talk to me then. You can always send me an email, and you can always just leave a message for me on Slack as well. But we can talk in real time between my time, 10 and 11. But certainly, if you can't make that, just send me any other communication if you need to. All right. Good luck.